Dear viewers, welcome you all to our show OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance with each other. Dear viewers, today our topic is CTEV. That is a very important topic and treated by Ilizarov. How it is treated by Ilizarov? Is it possible or not possible? And our speaker is the one and only, the magnificent presenter, the pioneer Ilizarov surgeon in Bangladesh, Professor Mofakhkharul Bari, sir. I would like to request Professor Mofakhkharul Bari, sir, to join with us.
Yes, thank you, Tanvir, for introducing me. Thank you very much.
Thank you very much, sir, for joining with us. Dear viewers, we have three academic experts with us. One of them is Professor Novikov, sir, from Russia. Another one is Professor Agarwal, sir, from India. And another one is Dr. Shamsul Hoda, sir, the Joint Secretary of ASAMi from Patna, India. I would like to request Dr. Shamsul Hoda, sir, to join with us. So welcome.
Hello and very good afternoon, Dr. Tanvir, and thank you.
Thank you very much. Dear viewers, we have another academic expert from Jordan, that is Professor Dr. Rami. I'd like to request the three academic experts to join with us. I hope they will join with us in the coming part of our program. Dear viewers, today the topic is CTEV, congenital talipes equinovarus deformity, and that can be treated by Ilizarov. That is the main important thing. But what should be the technique? And what will be the case selection? There are lots of questions there. I think you will get all those answers from the presentation of Professor Mofakhkharul Bari, sir. Now I'd like to request Professor Mofakhkharul Bari, sir, to start his presentation. Sir, would you please share your screen, please?
Thank you very much. Good afternoon, everyone. Dear friends, today I would like to talk on the correction of the club foot, which we can treat by Ilizarov. Especially, this is a very big chapter. And today I'll talk part 1 and part 2 I'll talk later on. Part 1, I'll talk on the neglected, relapsed, and resistant club foot. I always love to show these places where I've taken my training and post-graduation. This is our institute, Trauma and Orthopaedic Center, my present working place. This is my private center where I am doing all the time Ilizarov with other general orthopedic surgeries. This is Kurgan 4M. I always love to show this one. And you can see here the Ilizarov in children. What are the club foot deformities? You must see everything before going to do any surgery, either PMR or with any external fixator or with Ilizarov. The patient properly. And
Sir, we are facing some network problem.
Adolescent type.
Your voice is not clear, sir. Your voice is not clear, sir.
See,
it is interrupting.
Neglect and not possible to put all the cases in a single plate, So club foot covers congenital deformity. Here the sequential ways you can follow 30 years. What I've treated with the Ilizarov technique only, not only with Ponseti, these are all cases with Ilizarov technique. You can see age 1 to 33. 1, you can put at the age of 1, you can put in AMC, that is resistant, a very difficult case. So conservative treatment, you can go for conventional surgery. You can do for soft tissue destruction and at the same time doing osteotomy with the destruction by Ilizarov technique. Conventional method of treating relapsed or neglected before. In our experience of 30 years with more than 2 to 55 cases, a well-done Ilizarov would give satisfactory results from 1 to 33 years of age. After the age of 3, only the soft tissue release, you can do that. It is difficult for that. And Ilizarov technique for clubfoot surgery has opened up a new era of destruction of tissues to the medial side of neglected, relapsed, or rigid clubfoot, with or without soft tissue release, has been reported to give good results. Now, this Ilizarov apparatus is best suited for complex three-dimensional correction of the foot deformities, multiple joint functioning in different directions with different axes of rotation. This is very important. And with Ilizarov, you can correct all kinds of three-dimensional deformities. If you think about the cast, that is a limited mechanical advantage, and you can use cast only the malleable bones, in malleable bones. In contrast, Ilizarov method offers a more mechanically efficient method of stretching joints and soft tissues, and it can configure to apply only distraction of forces to the joints. One importance between the casting and the distraction treatment is that distraction can be modified several times. Whatever you do, you can do it. Whatever you like, you can change. But cast cannot be changed. Only once in a week or two, you can change the cast. And manipulation, if you go for manipulation, 35% success rate, whereas surgery, the method of treatment in about 65% of idiopathic televenous equine virus fit. Regardless of early and adequate surgery, the failure rate in the best series remains as high as 20%. When facing complex congenital foot deformities, failure is even higher. So, clubfoot deformity due to bony deformity associated with soft tissue contractures, you will get all the time, especially the late cases and relapsed cases. The soft tissue have contracted. What are these soft tissue? Capsule, ligaments, and musculotendinous units. When the soft tissue contractures are released by surgery, inter and periarticular fibrosis may occur, resulting in stiffness on the foot. This is very important. That's why whenever you go for PMR, you will get relapse cases most of the times. So our indications for Ilizarov surgery, age more than 1 year, 1 year for the resistant and very difficult cases in cases AMC cases, and adolescents and adults, relapsed, resistant, and neglected clubfoot, arthrogrypotic foot, children treated with multiple open surgeries when done, scared or infected skin from previous surgery, any deformity of the foot due to any other causes that may be congenital or shortening acquired is also treated by Ilizarov method after the age of 1 and more. Now, if you think about the conventional surgery, soft tissue release in most cases has given excellent results in the majority of cases and is definitely indicated in uncomplicated cases of clubfoot up to the age of 1. The conventional procedures are correction of the deformities, number 1, soft tissue release, tendon transfer, arthrodesis, and osteotomies. Dear friends, whenever we think about the Ilizarov, we must know the advantage. There are lots of advantages by doing the Ilizarov surgery. Minimally, you know that risk of neurovascular is very minimum and soft tissue injury, and you can control the infection also. And particularly very good for multiple operative surgery when done. Ilizarov is absolutely indicated for that. Any deformities can be corrected by this method, and residual deformity after surgery can be corrected during the post-operation period. Only one disadvantage is a greater learning curve, limitless, infinite. If you do Ilizarov, you will not be able to understand every day what you are doing, and it will give you learning and learning. That's why Ilizarov is always a greater steep or greater learning curve. And if you think about the Ilizarov treatment, we must have followed the 3 principles. Principles number 1, which was given by our Professor Ilizarov, law of tension and stress. Slow and steady traction on a living tissue creates a stress that is metabolically activated and that gives the histogenesis, histoneogenesis, or you can say tissuegenesis. Principle number 2, shape-forming processes acting upon bone tissue are dependent upon the magnitude of the applied load and the adequacy of the blood supply. Increased load is accompanied by adequate blood supply. The bone hypertrophies according to Ohm's law. Differential distraction is very important. Both convex and concave side are distracted differentially to correct the deformity. Now, two strategies, one for the constrained, another for the unconstrained. You can see here, the strategy depends on the age of your patient, presence of bony deformities, and at the same time, stiffness of the foot. Distraction, neohystogenesis, as I told you, this is very important, Ilizarov law. Whenever you are applying Ilizarov, you must think about the law of the Ilizarov. Slow and steady traction on a living tissue, I repeat it, which gives metabolically activated in both biosynthetic and proliferative pathways, depending upon the vascularity and functional use. And Professor Ilizarov showed in 1983, when you apply Ilizarov, you will get 330% blood circulation in that where you are applying that one. Biomechanics is very important. You know that adequate ring size, 2 to 3 fingers, minimally unsupported length between the rings, use of olive wires, thicker wires, so greater number per ring, maximum tension to control stiffness, and crossing of the wires. It is better to apply 35 to 60, but from 10 to 90, you can go in everywhere, every place, you cannot do that. So minimally 35 to 60 is very important. Now, application of the assembly. Dear friends, you can see here in the picture, consists of 2 blocks. A tibial block consists of 2 rings. And you can see here, the foot block consists of calcaneal ring with 3 rods, 4-foot ring with this vertical rod and the twisted plate connected to the calcaneal ring. Whenever you see this one, it will be very easy. When you will enjoy in the OT with the surgeon or assist, you will be able to understand how to do that. 3 ways of inserting metatarsal wires. You can see here, first method, inserting an olive wire from medial side to first metatarsal through all metatarsal necks holding the foot flat. Second group, you drill the olive wire through the neck of the first metatarsal and proceed, and you can, as a result, you can go through the second, third, and fourth, and ultimately second, third, and fourth wires. And last one, pass 2 wires, one through the, should capture the first and second, and ultimately 4th, 5th, and 3rd toes, metatarsals. Now, post-operative care is very important. It's very important. Whenever you do a surgery, one time you are finished. But after applying the Ilizarov, you must see the apparatus, how to do the distraction. You correct the varus first. If varus is corrected, then gradually you go for distraction. You can see you shall have to do the calculation, rule of triangle, and usually 2 millimeter distraction of the posterior rod. Simultaneously, the foreport is pulled up 1 millimeter per day by the vertical rods. After the correction is achieved, the apparatus is left in place 6 to 8 weeks in children and 10 to 12 weeks or more in adults. After removal of the apparatus, plaster cast should be given for a period of 12 weeks. This is to prevent the recurrence. Now, when you see that you are getting recurrence, if you do the overcorrection, you will not get the recurrence. In younger patients, there is greater growth, therefore chances of recurrence of the deformity are more. If the deformity is still, the chances of recurrence are more. If no orthosis is given after the removal of the apparatus, the foot should be splintered in ankle foot orthosis. That is, we are calling the AFO for a period of 3 to 6 months. And dear friends, in every surgery, there is a complications. Whenever you see the complications during distraction or after application of the Ilizarov, you can correct all these complications. Pin track, this is nothing. Premature conciliation or incomplete osteotomy when you are doing, if you see, you can go for another second time osteotomy. True contractures are common. That's why we go for putting the 1 or 1.5 K wires through the phalanges up to the metatarsals. And sometimes when you are doing the suction, you will get the subluxation or translation of the fragments. Now you can see the causes. You know that one: congenital, neglected, cerebral palsy, upper and lower motor neuron disease, spina bifida, arthrogryposis multiplex congenita. And you can see, dear friends, when you do the PMR in children, abundant tissue form leads to retracted fibrosis, which further leads to recurrence of the deformity. Why Ilizarov? I always tell this. Intelligent, first alphabet you see, you can go for lengthening. I, you can control the infection. Zigzag, you can correct the deformity. This is reliable, adaptable, reliable. You have got a lot of opportunity, and of course, the versatile, you are getting the victory. So when you are putting the Ilizarov, until now, all over the world, the calcaneum is fixed with the wire during Ilizarov correction of the clubfoot, violating the Ponsonby principles, leading to inadequate correction. So these are the, in cadaveric, you can see here how the ligaments get contracted in neglected cases, pronation of the foot, how we can correct, usually see, and this is the adduction and heel correction. Very simple. Put the hinge, 2 rings up, and gradually you destruct. The model on a fresh cadaver, you can see how your tendo-achilles is contracted, other tissue contracted. You can correct. How to correct the equinus, see the 2 blocks ring up and calcaneum, and you can gradually correct. And sometimes you need to go for tendo-achilles sternotomy. And now I'd like to show you some bilateral CTEV, 3 years old, you can see here. Then put the Ilizarov. Look at these. Here we have put here in the toes to prevent the clawing or contraction of the toes. And now in this year and this, you can see how beautifully corrected only after 3 months at the age of 3. So this is orthographic case, AMC. Treatment was done elsewhere by PMR. You can see rigid, and then came to me, look at both hands and the feet and the knee contracture. Gradually I have corrected. You can see follow-up, and you can see here after full correction of the hand, feet, and this is the view of the final view of the patient. He came to me with their parents from Saudi Arabia to treat this kind of difficult cases. And security of meningomyocele. When you see the meningomyocele, you will face this kind of arthrogrypotic foot. You can see here, so difficult, so difficult. Look at this. If you go for surgery, then you'll face a lot of problem. That's why these are the cases. That you can, in pandemic time, last year I did this case. See, all the time you should put the wires through the phalanges up to the metatarsal. And then after treatment, you can see fully corrected. As I told you, after removal of the apparatus, you must put the AFO. Bilateral neglected CTEV. See, again, treatment. After treatment, look, this is for the back side. See the sole of the foot. So beautiful corrected. All contracted structures. And this is what, now this is the normal situation. Now look at this, how the patient was standing with this club foot. Next, you can see meningomyocele bilateral club foot with a big ulcer here in the left side, the right side. See, this is the ulcer. If you cut this one, go for PMR, you'll get a lot of problem. Now, gradual, you are correcting, whereas, and then you can see, go for put the wires here, and radiographic view here. Then you go, I can see ulcer is healed, no ulcer. There was ulcer here. Now you can see, dear friend, this is after treatment. And bilateral relapse, CTEV with bilateral genuvalgum. Why relapse? It was done elsewhere surgery, and PMR was done, relapsed, and genuvalgum. This is the sequelae of PMR. See this cut here. This is the marking of the operations. And then came to me 3 months follow-up. This is after 4 months follow-up. I did the surgery here and here to correct the genu-valgum and to correct the clubfoot, relapsed clubfoot. Now we can see here, before surgery, how he was walking and how he's walking after surgery. Fantastic case, fantastic result with magical Ilizarov. Bilateral CTEV, relapsed, again PMR, sequelae of PMR. See, it's long back. I did this one. Now you can see the back side of the foot. And this is bilateral CTEV. See, after treatment, this is post-traumatic echoinocabovirus. I have taken here only one case. You can see here, this is also CTEV. So not congenital, but post-traumatic. This is, treatment with the Ilizarov apparatus. Now, only the follow-up after 3 months, you can see. This is the right side past echoinocavus. This is the sequelae of CP. Just you see, dear friends, 80 degree past echoinocavus, left side 40 degree, came to me, did with the Ilizarov surgery, and a little bit tendoachilles. Then 5 years follow-up, you can see from this side, CTEV, from this to this side. This is the follow-up. Now you can see here, total body AMC. Patient could not walk. Parents came to me for the last 12 years. Then the problems are here. You can see what are the problems. 6 major problems. All the major problems you can see here. How she is crawling. This is the X-ray. This is, I have done the Fisher Curtis apparatus in the knee. And this is sequential. PUS also done. This is when I was in Nicho. She was walking, crawling like that. Now you can see just after the removal of the apparatus, from that situation to this situation, you can do something whenever Ilizarov in your head. Look at this. Again relapsed, 3-dimensional, very difficult case. 13 years old girl came to me, PMR done. See the bone quality of the right side, 13 years. I have not done any osteotomy here. See, after 4 months of follow-up, sequentially, I have corrected all the components, that is cavus, adductus, equinus, and varus. Now you can see the back side and right side. Just compare. Smiling girl in standing condition. This is meningomyocele. Again, difficult case. You'll face a lot of problems with sequelae of meningomyocele. These are the cases. See sequelae of meningomyocele. Look at the foot, 180 degree already foot. Now, see how he was walking before doing the surgery. Now, this is the plaster and after removal of the plaster. Again, relapse CTEV, PMR, and shortening. I have done lengthening. And then you can see here, after treatment, from left side to right side. This is before and this is after. 15 years old girl, right past echoinocabovirus. You can see here, adolescent case, treatment, and then gradually you can correct the deformity. This is the follow-up after 4 months. Beautiful girl, beautiful face. See 5 centimeters shortening with CTEV. If you don't do Ilizarov, yes, you can go for surgery, but lengthening you cannot do here. Whenever you Ilizarov your hand, at the same time you correct the deformity, and at the same time you could go for lengthening. And this is the case. So after 6 months follow-up, you can see Alice test now negative. This is myomymeningocele, 18 years old during treatment. Now you can see here, this is the neglected CTEV at the age of 18 years. He did not get any treatment anywhere. This is neglected totally. and then put the apparatus. Now you can see the clinical picture, 4 centimeters shortening, 21 years old man with CTEV, and then corrected. This is of the treatment. You can see left and right side, you can just compare. This is CTEV right side, 27 years old adult, you can see. Then during treatment with the apparatus, this is just final follow-up, you can see. Now 29 years old man, again neglected CTEV from the village, 29 years old. Then you can correct. You can see, put the apparatus, and gradually you correct the deformity, and all the time try to put the wires in the toes. Otherwise, you will not get the foot correction. This is after 5 months follow-up, and this is already published in American Chronicon Relapse, Neglect, and Rigid CTEV, published in American Journal in 30th April 2019, 2 years back. And now I don't want to talk regarding these foot osteotomies. I'll talk on different lectures in foot osteotomies later on. Okay, so this was today for CTEV, and it is not possible to show you everything in a one lecture. So CTEV is a very big chapter. Regarding the foot osteotomies, I'll talk on later on. And dear friends, I would like to say regarding this CTEV, you can correct fantastically if you know the basic principles and basic ideas of CTEV. You can correct everything, three-dimensional deformities in CTEV you can correct. And in my conclusion, I would like to say Ilizarov method is the best dynamic method for correction of the relapsed, neglected, resistant clubfoot CTEV of various ethologies, especially in the age group 1 to 33 years, where deformity is difficult to correct by simple procedures. Technical and biological opportunities to achieve deformity correction goal in traditional are you can achieve a good correction, good functional, and good cosmetic results. And I always love to show this one also. Why you are getting complications by Ilizarov? Because if you the proper technique, if you violate the original Russian principle, lack of skill, meticulous, intelligent follow-up, lack of patience, and hybridizations. So these are my all, Kurgan fellows, my mentor, teacher, and these are Director Govind. And in our country, we're doing a lot of cases. And till today, I have 91 international publications and 7 books. And see what I have shown you. I always love to show this one because this is totally related to the Ilizarov. Evidence, science, and surgical skill of the surgeon. That will give you fantastic result when you do all kinds of these kinds of deformities. So thank you very much again for your kind attention and kind patient hearing.
Thank you very much, sir. Thank you for your excellent presentation. It's a great honor for us that Professor Agarwal sir has joined with us. Sir, welcome to our show. That is Orthopedic Solution Academy, and this is the first time we have you in our show, and it's a great honor for us. I would like to introduce Professor Agarwal sir with you. Professor Agarwal sir is the past president of ASAMi, and he has joined with us from India with a very busy schedule. Sir, I would like to request Professor Agarwal sir to say something, and if you want to present something or show something to us, then it will be a great pleasure for us. Professor Agarwal sir, would you please share your screen with us?
Sir, please unmute, sir. You can see Dr. Agarwal is also there. Please unmute, sir. Agarwal, sir, please unmute. Yeah, we can hear you, sir.
So we can see your slide. Please make it full screen, sir. Yeah. It is not yet full screen, sir. Would you please make it full screen? Then it will be easier for us to watch.
No. Presentation last week. Last week. Just a moment, please.
Oh, sure, sir.
Last week. Presentation. Last week. Last week.
Yes, sir. It's okay, sir. Yeah.
Okay, sir. Full period.
Make it full screen again, sir. Make it full screen again, sir. Yeah.
Full screen. Full screen.
Slideshow mode, sir. Slideshow mode, yeah. Come on.
Okay, sir.
Okay.
Yes, sir.
Yeah.
So, for a very, very long time, there was a lot of confusion about how to manage the neglected clubfoot. So the Ponseti came, and then the treatment has started of the clubfoot. I tell you, this is the marvelous surgery, and this is the best thing which a person can add to treat the neglected clubfoot. So before we start the clubfoot, we should know by three angles. From the frontal plane we should see, and the sagittal plane, and from the horizontal plane. This concept one has to make in your mind, otherwise it's very difficult to treat the clubfoot deformity. Because the Ponseti told that there is a pronation of the forefoot in comparison to hindfoot. The kite technique, we were adding more pronation. So the concept have changed now. So this is the responsible is the plantar fascia, which is causing the pronation of the forefoot. So if first of all you take the photograph and see from the front, and another is there is a adduction of the forefoot. So whatever you want to do this surgery, first of all you see how much adduction is there, how much pronation is there. Third, you take the photograph from the plantar view. So actually you should know how much adduction is present there. And another thing is that you should see from the back. So most important is how much varus is there. So the things in summarize. So there is a pronation of the forefoot, there is a varus of the forefoot, there is adduction of the forefoot, and in the last is the equino in the sagittal plane. One has to see how much equino or equinocavus. These are the four deformities that one has to consider before starting the. We always take the photographs from various angles and we measure it, how much is the deformity. We have made our own protocol that 0 to 2 years, this is we can correct with the positive corrective cast. Then 2 to 5 years, we have developed MICC, will show the cases minimum invasive cast correction. And more than 5 years, Ilizarov based on the Ponseti principles. Only they accept that the atypical clubfoot, there we can start after 1 year or 2 years. That was told by Dr. Bari. So we are dealing here the neglected clubfoot for 2 to 5 years. We recommend a new technique that is called MICC, minimum invasive cast correction, because the notorious ligaments are two: plantar ligament, plantar fascia. So we do the first of all plantar fasciotomy, then we do the serial plaster cast, and in the last percutaneous TA tenotomy. For last 20-25 years, we have not opened the tendoachilles, because when you open the tendoachilles, paratendon is finished, and after that, when we have developed we have seen that, so there is always adhesion surrounding that. So for 20-30 years, we have abandoned the percutaneous we do always percutaneous. We do not open the tendoachilles, because it will be your experience that after doing the open surgery of the tendoachilles, if there is a recurrence, you will find that there is only fibrosis. That is very difficult technique phase. So, for example, this is a 2 years to 7 month child neglected clubfoot. If you see all the deformity, adduction, varus, equinocavus, and plantar adduction is there. These are pre-treatment photographs. So first of all, what we have done, because notorious ligament is the plantar fasciotomy. So what we do the first of all, as soon as the child comes to us, we do under local anesthesia. This is very we at the base of the calcaneus, we do the percutaneous tenotomy. Mind you, this is a very dangerous technique, because the calcaneal artery is passing that area. So your sharpness of the knife should always be towards the calcaneus. If you have done a mistake, so there will be blunder there will be the damage to the plantar artery, and severe bleeding to occur. In the cases of the Ilizarov foot, we have found that initially it was okay, and after that, what happened that there was a bleeding from that. So it's a very simple technique. You feel the calcaneus and feel the tendon. We do the percutaneous tenotomy. After that, you can see that after various plaster technique, most of the deformity is corrected. Only there is a equinus is left there. So what we have done, we have just cut. This is the number 15 blade, and if the child is very small, we are using the knife cutter blade. You just feel the tendon and just do the 90-degree rotation. So what happens? The tendon is cut there. So after that, you can see that the result is fantastic. It's a plantar flex, adduction is corrected, varus is corrected. Final photographs after plantar fasciotomy and tendoachilles tenotomy. There was another boy. It was a 5-year-old boy. It was having the very severe clubfoot deformity. So what we have done in the same way, we have done the percutaneous tenotomy, plantar fasciotomy. You can see the mostly deformities are corrected, and after that we have done the tendoachilles tenotomy. So all the deformity is corrected. What happens? Sometimes the adduction deformity left there, that is not corrected by the plaster. So what we do, we apply the frame and we correct the adduction deformity by the Ilizarov. This is another boy. We were very much excited. We were seeing that after 6-year-old child, we have treated by plantar fasciotomy and TA tenotomy, and after casting, you can see the final photographs. It is a plantar foot there. This is the percutaneous tenotomy, plantar fasciotomy, and it is the percutaneous tenotomy of the tendon Achilles, and this is the final photograph of the child. Now we are dealing with the recommend correction by Ilizarov external fixation, but based on the Ponseti principles. Neglected clubfoot more than 5 years. I was going to another city to conduct the clubfoot conference. You can see that they have shown this. This was the PMR, post-medial release was done there. So what happens? A lot of fibrosis whenever you do open surgery. Always there is a lot of fibrosis take place, and these fibrosis are responsible for the contracture. So whatever I have seen many cases of the PMR, they have been spoiled. Surgery, resurgery, mostly done, but the deformity is not corrected. So now we are doing the Ilizarov external. Up till now, all over the world, the calcaneus is fixed with the wires during the Ilizarov correction of clubfoot, violating the Ponseti principles, leading to inadequate correction. So we never give an initially wire to the calcaneus. Most orthopedists agree that the treatment of clubfoot deformity should be non-operative because surgery in the clubfoot is invariably followed by deep scarring. The abundant scarred tissue formed after surgery leads to retracting fibrosis, which further leads to recurrence of the deformity. Thus, it is advisable to do the minimum surgery. Ilizarov external fixation can be used in older children or those with very stiff foot because the fixator is versatile and flexible in application. During the construction of the PAVE, we have applied the principle of Ponseti in Ilizarov fixator. So our technique is frame application, step-by-step correction of the pronation of the forefoot, then metatarsal adduction and heel varus, and in the last, equinus is corrected. So it's a very simple procedure. We put 2 rings in the tibia and 2 wires in each. So it's a very simple 2 rings and 2 wires. Another wire is in the full ring. We have given that because it's a very difficult to correct the pronation of the forefoot. So there is no problem of the walking there. Full ring upright through the talus and fixed with the oliver because the base is at the Ponseti treatment is the talus. So we put the 1 oliver and full ring applied through the base of metatarsal and fixed with 2 wires because we were trying to correct the deformity without applying the full ring, but it's a very difficult because the rotation is not possible. So we have put the full ring there. So we have studied the cadaver there, how we were knowing the where to put this question or asked. So where to put the wire? So we have done the fresh cadaver there. Model of the fresh cadaver is showing olive wire applied through the head of the talus. No, you can't go the neck of the talus because this is a very hard structure there. So we put the 1 olive wire through the head of the talus, and this is the 1 wire through the 1st and 2nd metatarsal. Another wire is 5th, 4th, 3 metatarsal. So I think it's a very simple technique, but you have to know where to put the olive wire. First of all, what we do, the basic principle is there is a soft tissue contracture. So what we do, first of all, we give the distraction. You can see here. So we every 3-4 days, 5 days, we do distraction. So what happens? All the ligaments, they become supple. So when they become supple, so what we do 1 whole rotation here. You can see here. We change our thread rods, and by that way, we do the pronation. Mind you, before doing that, we always do the plantar fasciotomy. So what happened? Corrected by distraction whenever all the deformities of the pronation has been corrected. So what happened? Now thing is adduction. So this is the hinge model. Here we do the fractional distraction there are the 2 millimeter, 1 millimeter, and sometimes 3 millimeter on the medial side, lateral side 1 millimeter. So you can see that the deformity Whenever the deformity 50 to 60 degree is corrected, then we go to the another deformity, that equinus. So what happened? We have done the study on the model and the press advert. You can see that these are the model there, and gradually we have tried to correct the deformity. And what happened? What we have found, normally there was adduction of the heel there, whereas deformity. As soon as we do the correction of the adduction, we make the abduction. So what happens? When we do the adduction, now question arises, why the supination? Because there is a head of the talus and navicular. Until and unless you don't do the supination, the head will not accommodate that navicular will not accommodate the head of the talus. So when we do the supination, after that we try to abduct the forefoot. You can see there. So what happens? We have done this in the press model, that as soon as we corrected the deformity of the adduction, make a neutral or more abduction. So what happens? The foot goes into the from varus position to the neutral or sometimes valgus position. So that is most important. This question is asked how much flexion, abduction. Usually 30 to 40 degree because these are old children. Ponseti says 70 degree, but in these cases 30 to 40, 50 is only possible. That is not possible. So our basic principle is first we correct the pronation, and after that we do correction the adduction. And correction done in the last after achievement. Equinus. Equinus is correction is done in the last. Frame configuration is changed now. Then we do the percutaneous subtendonic tenotomy, or usually we are doing the VY plasty. We can do the tendoachilles lengthening by rate of the 1 millimeter per milliliter. So this is the model of that. What we have done, the half ring, we make the full ring to the half ring. 2 rings are there, and we put another ring that is in the calcaneus. So half ring is applied in the forefoot, half ring is applied in the calcaneus, and equinus is corrected by distraction the 1 millimeter per day. So as in the bone there, we do the correction of the lengthening, because here we have done the percutaneous tenotomy, and after that the lengthening of the tendon is possible. So this is young girl, aged 17 years, with a bilateral clubfoot deformity. 1 or 2 surgeries were performed there. So after that, we applied the same. I think first of all, we have corrected the pronation of the forefoot. And after that, when this deformity was corrected, so we have applied another thing here. You can see there, we applied the equinus by putting the calcaneus ring there. And you know, some people say that folding is difficult. We make a special sandals so that they can walk nicely. You can see the pre-operative radiographs. There is about total line is 180 degrees. See where equinus is there. Adduction is 60 degrees. So now common problem is that what happens when we are going to correct the equinus deformity. This is the talus. It goes always anterior subluxation. So you always make the distance of the talus by distraction 4 mm. If you have not observed that, what will happen? That the talus will come anterior subluxation. So this is a very, very important thing, that during the correction, your talus joint, ankle joint space should be not less than 4 mm. Otherwise, you will be in that great problem. So you can see that beautifully all the deformity has been corrected, adduction has been corrected, equinus has been corrected. And in the last, this is the photograph of the girl. It's how beautifully, for many years we were doing the post-operative surgery or many other surgery, lot of scar takes place. But why Ilizarov? The foot is fully, it looks to be the normal foot there. How much severe it was there. You can see after the surgery, it has become completely normal. It's a very, very important case. This girl was suffering by the chorda equina syndrome. So what happens is charcot arthroplasty of the foot and ankle, ulceration of the rhodum, the tibia. She has gone, a young girl, about 18 years, gone to every part of the India. Everybody is told that there is no answer than the amputation. You can see that it is so much deformity that she is walking on this tibia. Very, very severe deformity. A big ulceration was there. It was a very, very challenging case because everybody told that it's a treatment is useless. You go for amputation. So what happened? We have applied the frame, and gradually we have corrected the deformity. And gradually, when we have corrected the deformity, adduction has been corrected. So what happened? We applied the frame. It is a deformity before final X-ray. We have done the plantar orthodesis by putting the retrograde nail there. You can see the charcot joint foot and ankle orthosis because it was an unstable ankle joint. So what we have done after that, when we have corrected the deformity, we have put the nail there. And you can see in the metatarsal there was deformity there. So we have put the screw. So it's a very fantastic rule. It is the final photograph of the girl. It was a pre-operative, and this is the final photograph of the complete correction. You can see the girl, how beautiful. Now see, at present is a computer soft engineer there. So Ilizarov gives life to many, many thousands and thousand persons, patients, boys, girls, who were amputated before this treatment. After that, she told me that she has gone to every part of the India. Everybody told that she need amputation. So my request to all of you, because it's a long learning curve, but if you learn this technique, it will be very human. The problem that it serve to the humanity. It's another boy, 19-year-old boy with the bilateral clubfoot deformity. This is a very, very severe deformity. You can see that even the same man, the 90 degrees, the adduction deformity at both the leg, 19-year-old boy. So gradually, we have corrected the deformity. Gradually. And this is the gradually deformity is corrected. So what we have done, we have V osteotomy. Because it's very severe, so we have done the V osteotomy. And you can see how beautifully the foot is there. And you can see that osteotalos calcaneus was the foot there. So we have done that. And you can see that here we have done the V osteotomy. But usually what I do, I put a wedge there here, because before removing the wedge, it's the only thing is that the foot becomes short. But I personally found we do the osteotomy, but percutaneous, we remove a wedge from both the sides here. You can see there. So thank you very much. I have written a book on the clubfoot. That clubfoot is distributed even in the United States in the 44 countries. So it's a very, very necessary that everyone should read that book so that they should know the concept there. This book was presented, even sometimes this book was distributed in the Ponseti Center also. So our period of study was 2000 to 2018. 0 to 2 years with Ponseti case, 1173 cases. 0 to 6 years with the MICC, 121 cases. More than 6 years, we have done the Ilizarov 52 cases. So what is conclusion? Ponseti corrective cause is now the standard treatment of clubfoot 0 to 2 years. For clubfoot in 2 to 6 years, we recommend MICC. For neglected clubfoot more than 6 years, we recommend Ilizarov based on Ponseti principle. Wires should pass with talus, not calcaneus. With our series of clubfoot, probably the largest in India, we recommend that open surgery is almost obsolete in the clubfoot. So we do a lot of cancer of the clubfoot. In every child, we get a lot of children there. So we have shown about in the clubfoot about 4,000 to 5,000 children in various parts of India. Thank Thank you very much, sir.
Thank you very much, sir, for your amazing presentation. And I think we have learned a lot from your excellent presentation. We have Professor Novikov, sir, with us. He has joined with us. Sir, welcome to our show. And I would like to request Professor Novikov, sir, to say something regarding our topic, that is CTEV treated by Ilizarov. Professor Novikov, sir, would you please? Sir, you have to unmute yourself first. We can't hear you, sir. No, we can't hear you, sir.
Please unmute,
You
sir.
have to, please unmute, sir. There is a mic sign below, and you have to click that mic sign so that you will be unmuted. Professor Novikov, sir, we can't hear you, sir. Professor Novikov, sir, we can't hear you yet.
Yeah.
You have to unmute yourself, sir. There is a mic sign. There is a sign of a figure of mic. You have to click that sign, and then you will be unmuted.
Nie slyšno. Konstantin Igorovič, nie slyšno.
Dear viewers, it's a great honor for us, and I think it's a very memorable day that we have three legendary orthopedic surgeons with us in our program, that is Orthopaedic Solution Academy. One from Bangladesh, the pioneer Ilizarov surgeon, Professor Mofakhkharul Bari, and another one is from India, Professor Agarwal sir, and the academic person, Professor Novikov sir from Russia. And definitely we are very glad to have Dr. Shamsul Hoda sir, and he is the young, energetic and enthusiastic Ilizarov surgeon in the coming part of the Ilizarov study of our life. And it's a great day for Orthopaedic Solution Academy. I think Professor Novikov sir is trying to unmute himself. And during that period, I would like to request Professor Mofakhkharul Bari sir to say something, as because of both of you present excellent presentation today. So during this time interval, I would like to request Professor Mofakhkharul Bari sir to say something regarding the club foot and the varieties of treatment procedure. A very interesting topic.
Thank you very much. First of all, I'd like to congratulate Agarwal, my friend. How are you? Fine? Very good, fantastic lecture. Several times I've heard this lecture, and again, remembering everything all the time. And he rightly showed everything, starting from the Ponseti up to the Ilizarov. And a little bit difference, I told you that I do in case of AMC club foot at the age of 1, in Kurgan they are doing at the age of 2. It is very difficult for AMC case club foot to correct by Ponseti technique and casting. Otherwise, I agree with him all the time that what he showed. It's a good lecture. Thank you very much. Thank you again.
Thank you very much, sir. And now I'd like to request Dr. Shamsul Hoda sir to say something. What is your experience regarding the management of CTEV by Ilizarov?
Thank you, Dr. Tanvir. I again say that I'm really glad witnessing this day that we have all three legends from different countries, Bari sir, Agarwal sir, and Novikov sir. We are with him. It's a real pleasure for us. We have learned a lot from them over years, and now we have again learning from them by this webinar. Thank you, sir. Thanks a lot, sir. Regarding my experience with Ilizarov in club for children, I usually follow in younger children. I do Ponce technique, castic, and in older children more than I use around less than 5 resistant. I use just fixators, and after 5 I use Ilizarov fixators in all the cases. From 5 to adolescent cases also, I've been using Ilizarov. But just in young children, around 2 years, 4 years, I have been using JES. And definitely in infants, using Ponce technique with casting. And all have been doing very well.
That's great.
That's
great. Yeah. Hope you will show us how we can apply the just fixator in the coming part of our CTV program, and that will be a great learning for us also. And we are waiting for that. Professor Novikov, sir, can you share your experience with us? Is it okay now? Would you please say something? Professor Novikov, sir, can you hear us? Would you please say something so that we can clear that? No, still now we can't hear you, sir.
Sir, are you using microphone on laptop? If you can unplug. Novikov, sir, if you are using microphone on the laptop, you can unplug that. If you are using microphone, you can unplug.
Sir, okay, I think Professor Novikov sir is facing some sort of difficulties there. And finally, I would like to request Professor Agarwal sir to say something regarding our program, that is Orthopedic Solution Academy, as because of this is the first time we have you, and regarding the advanced management of club food by Ilizarov for the young learners such as our team.
Yeah.
Professor Agarwal sir.
Yeah, sir. Actually, the main thing is the club food we were having for the long centuries. But initially, about 20, 30 years back, I started my practice in 77. So for many years, we have operated the case and we have applied the case, exploited the cases there. So I have gone to in 2000 to Dr. Pansetti centers. So then I learned this technique. So I thought, why not to apply this technique to the Ilizarov technique? Mind you, but the main problem was that there was only one book that was written by Professor Pansetti, but it was not very explainable. So when I came from 2000 here to India, so we have thought that we should write like Bible, like Gita, because everybody reads there. So we should make the book like this so that everybody of the world should, our language, our principles, our theme should be such. We read the Bible, we read the Quran, we read the Gita. So why not book on the Pansetti technique? So we have tried to read that, and you'll be assured to know that all over the world, this book is, the people read this book. So our main aim with the Dr. Bari and so many learned persons are there. We should like that everybody, we should give the teachings, our knowledge, share that. So that what happened that everybody of the world, because the main problem is that I tell you is still there are a lot of gap of the Ilizarov books. So we are trying to put that. So that is our, for example, yoga. It was a okay, Ramdev ji had. So yoga has developed all over the world. So my theme is that all, yeah. So what happens that we should give the theme and we should teach, because still I get the patients. They say, sir, I have been plastered for 15 times. I have been operated open surgery, still there is a problem. So my aim is that it's a very simple technique that you should and correct that the Ponseti club foot. I tell you, there is no another technique for the neglected club foot more than some applied the Joseph fixator, some apply simple fixators, but there is no, it's not very forceful. So my aim is that, my suggestion is that everyone use that after 2, 3, 4 years when the foot is not corrected by the past. Second thing, even in the process early stages, lot of orthopedic surgeons from India, they are concentrating. So that is the purpose of this webinar, is that the all over world they should see how the technique, how much is the correction is that. So I'm very, very thankful that all the persons who are organizing things, because I tell you, lot of club foot have been neglected and spoiled because the persons don't learn this technique. So that, and after that, it's a very, very good technique. I learned from Bari, I learned from Kurgan, and many other orthopedic surgeons. Then we are able to conduct that, and we can say, even a Dr. Bari can say, I say 101%. If you are the perfect in that, you can imagine that girl. Everybody told that you need amputation. Not that girl. So many other fellows are there who has been documented, or their life has become handicapped. Only thing that you should know the principle. So it's a very good technique. But the only thing is, I tell you, in India and abroad, that people don't know how to put the wires. It's a very, very simple technique. By this webinar, lot of people should know where to put the wire, where to put that. Thank you very much.
Thank you very much, sir.
I think Professor Novikov, he has been to our hospital.
Yeah. Yeah, definitely, sir. We'll go to Professor Novikov, sir. Sir, can you hear us? And please say something.
Oh.
Professor Novikov, sir.
Sir, we still can't hear you, sir.
We still can't hear you, sir. Professor Novikov, sir. I think there is a network problem there. So it becomes a one-way communications, only visual communication, not verbal communication there. We are eagerly waiting for Professor Novikov, sir.
He is telling, he is listening us very nicely, and he is working.
So, Professor Bari, sir, would you please make your phone in a speaker mode and let Professor Novikov, sir, speak on your phone so that we can hear that. That is
Speaker.
There is an alternative way. Yes, sir. You make your phone in a speaker mode and take the phone to the.
Ashraf, only one question. When you have severe equine deformity, what you will do with finger?
Pardon?
Well,
usually we put so many wires for each finger. Did you use this technique?
Yes. Have you followed his question? Okay, his question is why you are putting wires in the fingers or not, in the toes. I showed you, I put all the time the fingers in the phalanges, you know, in the toes, up to the metatarsal bone. If you don't do that, you will get contraction, all the toes. I do that. You missed my lecture. No, because question is, do you put wires in the toes or not? Agarwal.
Yeah, basically, where to put the wire, where not to put the wire. So what we haven't find out where the deformity is severe. You apply the plaster bands there, other things. If they are not corrected, that we assess pre-operative. Otherwise, what will happen? You have corrected the deformity, but there is a flexion and adduction of the toes. So it is must that we should put the wire in each and every case. That is
Right.
my opinion.
Right. So you are satisfied?
Yeah.
Novikov.
Sir?
Okay, he's okay. Now he is listening. He is listening our voice, but we cannot
Yes,
listen
sir.
his voice. Thank you very much.
Yes, sir. Thank you, Professor Novikov, sir. Thank you, Professor Agarwal, sir, and thank you, Professor Bari, sir. Definitely, I would like to give thanks to Dr. Shamsul, sir, also for being with us. And I hope we will do the CTEV part 2 in the coming Friday, as because of it's a vast chapter, and we want to know many things from this legendary person, and we don't want to miss that things also. And dear viewers, I am Dr. Mohammad Tanvir Ashraf. I would like to thank Raj TV for helping us to arrange this type of program, and definitely Renata Pharmaceuticals Limited for sponsoring this program. And dear viewers, I hope we'll see you in the coming Friday with another topic like a CTV or any other topic during this COVID-19 pandemic situation. Be aware and keeping distance with each other, and definitely wear mask. And till then, I want to say goodbye to everybody. Goodbye.